Okay, so if we could go ahead and get started on our closing panel session here. And the title of this session is Delivering Affordable Cancer Care Paths Forward. I do want to place a little bit of context before we start into the panel itself, and that is to remind us what we heard in the very beginning of this, and that is that the conversation we've been having these last couple of days is actually going to feed into a larger IOM consensus study addressing a number of issues around cancer care. And that committee is actually, many of the members of that committee are in here. Not coincidentally, Patty Gans is the chairman of that group. And that the grist of the mill from what we've had here in this last day and a half is actually going to be fed into that committee's work. So all of the really good ideas that were presented during this meeting are actually have a direct line into that committee. So I've been asked to take just about 10 minutes and summarize the last day and a half. There's about 47 things wrong with that assignment, but I'm going to do it anyway, very quickly. I do want to say that because we covered so much ground and so many things in the last day and a half, I'm not going to do any one presenter or any one area justice in doing this. But I do think it's worth us stepping back up to a 50,000-foot level and just reminding us before we get into a discussion of what others think is our path forward to take a few minutes and reflect on those things. So as I was thinking about this last night, how do I take yesterday's stuff and organize it? I began to have this vision that Amy Abernethy's Wild Wild West slide ought to be the cover for the report that comes out of this, and for those of you who saw it. And to borrow from Lee Newcomer's approach a little while earlier, I think one thing that there was violent agreement about yesterday is that the current affordability trends are not sustainable. So we obviously have to do something different. And the challenge that was put before us in all of this was to talk about how are we going to reduce costs, how are we going to meet increasing demands, and how at the same time we're going to assure quality and patient outcomes. And actually I started thinking about those. They sound a little bit like a couple of political campaigns in some ways. So as I thought about this, one of the ways I was thinking about it was in the context of dynamic tensions that I heard in the conversation yesterday. And I have a number of them that I want to just throw out there without a lot of explanation, because I do think they give us a framework for thinking about some of the things. Now, these dynamic tensions are not choices. We don't have to choose between one or the other. But as we seek solutions, we have to account for both sides of these. So the first one that I want to talk about is one that Harvey Feinberg put on the table yesterday. That's the affordable to whom effort, and we are affordable to whom question. And we had a lot of discussion yesterday about what's affordable to patients, what's affordable to society, and that is a dynamic tension that runs through this entire exercise. Then we had a lot of discussion about the importance of tackling the whole system. And Harvey also challenged us along those same lines. At the same time, we had a lot of conversation about granular issues and even used that language. So once again, we have a dynamic tension between tackling the whole system and addressing specific issues on a granular basis. We also talked about the importance of trying to look at the whole cancer problem and figuring out how best we solve this. But we had one small reference to the other side of that equation, which is that many of the underlying issues affecting cancer are actually driven by socioeconomics that have nothing to do with the way the system works. It is a reflection of what happens in the system to those folks. And at some point, I think we have to also pick up the other side of the equation and ask ourselves, what are we going to do about those underlying socioeconomic drivers? Similarly, we talk a lot about cancer solutions, but as I listen to some of the things, they're very specific to cancer, but the flip side of that is they're also, the solutions of them are actually reflective of the things that we're facing in other chronic diseases. So we have system solutions that are beyond us alone, and we have the very specific solutions, another dynamic tension. We talked a lot about fostering innovation and looking at ways that we can foster innovation, but on the other side of that equation, we talked about how are we going to pay for implementing the innovations that we foster, even in an environment where we know we have underlying economic structures. So again, a dynamic tension at work. A lot of discussion was given yesterday, the notion of doing evidence-based things, if you will, And then on the other side of the equation, we have no evidence. The best way I can frame this just in a simple thing is it's the difference between the randomized clinical trial and the trains out of the station model that we heard yesterday. And I think we have to understand that society is moving faster than we are, and sometimes, and that gets us in that situation. And yet on the evidence side, we all understand that we need good evidence, we need better evidence. We had a lot of discussion yesterday, and I think it was a good discussion. I think we all probably have some violent agreement around this as well. We talked a lot about transparency. At the same time, we heard some of the they can't handle the truth conversation as well yesterday. I would argue that that's less a dynamic tension than a few people, but nevertheless. We had discussions about what do we mean by cost? Is it out-of-pocket cost to the patient, or is it total cost? And we again had arguments on both sides of that spectrum. Rationing versus rational, and the conversations that we had, number of ideas generated around that. We talked about stewardship, good stewardship of resources that we have as a country. But we also talked about the system being aligned so that we need to do other things sometimes to make a living. And this gets right at the heart of the ethics question that was being addressed today. We also talked about being systematic and thoughtful and evidence-based about what we're doing, but we heard several speakers today and yesterday talk about the sense of urgency that we better have. We don't have 5 years to figure out some of the solutions to these things, and we need to move. Again, I'm not presenting these as dichotomies and choices because both sides of these have merit and we have to talk about them. So we had a really good, interesting talk yesterday related to, we've got many more drugs than we ever had before for multiple diseases, and within a disease, many more drugs, which is a good thing because it provides us with options. But this morning, we talked about managing the complexity of looking at those kinds of drugs. We talked a lot about the technology explosion yesterday, and but at the flip side of that is we have a societal framework that says we love technology. We have to have the next best thing. You know, how many of you have the next best thing already? Can you do this thing that they talk about on TV? So the point is we have this love of technology that's sometimes independent of technology for what? And how is that going to play out as we move forward? Anyway, the last thing I would say, which came up in our last conversation that I think is important, is we also have a culture that says we're going to stand alone as a country. We do our own thing, and we think we know best. Against the other side of the equation is where we have a lot of other countries that are trying some of these things and worth thinking about their models. So I'm going to cherry pick a few more quick things, and then I'll be done. So as I got to thinking about this, and I'm truly cherry picking now, society, our culture and our society, one of the issues that I struggle with a lot, and I heard some of it in this meeting, is we like to demonize and blame people now. We've moved into that model of saying, you're responsible for this problem, which implies you're the fix, or we can fix you, or something like that. I liked Zeke's statement yesterday, we are the problem. We all are the problem. I think that's really important for us to understand. The demonizing doesn't really take us anywhere because we're all part of the solution. And I'm assuming that, Zeke, that was a paraphrase from Pogo. We've met the enemy and we are they. Another area around this is disparities. We talked about disparities yesterday, but a lot of our system solutions weren't talking about solving the disparities. And I guess the issue for me is, are we still serious? Are we really serious about solving the disparity problem, as well as getting our entire system in line, as we talked about doing? And lastly, in the societal side of this, talked a bit about prevention, a very little bit about prevention. We heard a little bit more this morning from Kaiser and a few others who were talking about it, but we have no culture for prevention. And I love the comment that Jim Marks from Robert Wood Johnson Foundation is fond of making, and that is the only way we're really going to afford new expensive therapies is if we lower the number of people who actually need them, and the best way to do that is by prevention. And so we need to get on that. In the practice area, we talked a lot about this issue, and I'm not going to say no value, I just did, but I'm not going to say that. Low value, or whatever the threshold is, but this idea of reaching consensus on things that we believe are not beneficial to patients or society in this effort. And one issue I wanted to raise, though, just very quickly, and it was brought to mind today by the community oncologists who presented, and I also appreciate your being here, very much taking time from your practice. But I think what's really important here is to recognize that one of the problems we have in a nation is we never scale up the good things that we do well. We have to scale up. So we have 3 great examples, and there are, I'm sure, many more out there, but the question is, how do we move them out to broader society quickly and rapidly so that we all benefit from them? Pricing, I'll just say one quick thing. I was out in the hall after we had some discussions. This was early in the afternoon yesterday, and about a half a dozen people in some way or another says we've got to fix the payment system. We've got to fix the payment system. We heard a lot of ideas for doing that. Our community docs had some ideas today that I think are important, but we all understand we have a long ways to go there. I do want to say something about patient-provider communications. We talked about repeatedly in this the importance of communicating good information to patients. Physicians need good information from each other and from their reliable sources, but we also put a couple of holes in there, and one of those is that we're not comfortable having some of these conversations. The whole discussion about whether people can handle the cost piece or not is a really important underlying problem I think that we need to talk through. And finally, we talk a lot about policy and regulation, and we had a lot of good ideas about that, but I just want to say a couple of things really quickly. Around the issue of policy and regulation, I think it's very important for us to understand that part of what we face here is what are we doing at the federal level, and then the distinction of what are we doing at the state level. And quite frankly, I think a lot's going on federally, but there are things happening locally or at the state level that are impacting it as well. And I don't want us to avoid this notion of voluntary changes and, if you will, voluntary policy. I heard it yesterday, this notion that the accountants won't let us. Okay, the accountants won't let us. Oh, we're victims, right? I don't know about you, but I'm not a victim. I don't think we should be going there. The last couple of points I want to make very quickly, and I'm sorry for doing this really rapidly, is just I want to come back to where Jesse Grumman started this morning. At the end of the day, as Dr. LaSalle-Lafall often said, is the patients are the object of our affection. We should be driven through the lens of what patients and how we are going to help patients out. And I really appreciated her comments this morning on patient-centered care, what that looks like from somebody who's living and breathing it. I also think the comments that were made around communications between doctors and patients on these things and getting a clearer focus about that is really quite important. We talked about their financial vulnerability, and Lowell or somebody used the word financial toxicity yesterday, which I think is right up the alley of the way we should be looking at this. But at the flip side of that is we also talked about a public demand where we're throwing up billboards and ads and et cetera that we're trying to influence people to go down certain levels and demand certain things. And then the flip side of that is a society which is better connected to information than it's ever been, and our ability to see people and patients who come into practices actually armed with information and wanting to challenge us about where we're going and what we're thinking, and we have to be prepared for that. But at the end of the day, there were a couple of references to it today, a couple yesterday. Mostly, not everybody, but most patients simply want the truth from us. And included in that is the truth related to prognosis and costs, and I believe we deserve that truth. So on the other spectrum that I would throw out there, I'm an optimist. I heard some pessimism or cynicism yesterday. We need both to drive a system. But at the end of the day, if we don't believe we can make change, then we ought to be out of the business because we do need to make that change. I love the introspection I saw in this meeting. I love the fact that over the last 5 years, I've watched this huge shift in our willingness as individual collections of skill sets related to cancer to have honest conversations about what we do well. And I loved Amy Abernethy's talk yesterday when she started out by saying, here's my 66-year-old patient. I don't think I did that person the best thing I could do because I was in a hurry. That kind of honest introspection gives me great optimism. We'll move forward. Last comment, very quickly, is to simply say one of the great failings of the last 4 years around health reform is that we have never adequately explained to the American people what we were doing and why we were doing it. We're talking about making huge transformational change in our system. We had lots of ideas. We need to bring the public along with us, or we will find ourselves right back in the uninformed debates that we did around death panels and things like that. So thank you for your attention to that quick summary. With that, we have 8 distinguished folks with us today. And so I'm going to introduce them very quickly, and I'm going to introduce them all at once. And then I'm going to switch the order, and we're going to start with Paula and Therese, and we're going to come this way. I figured if we're going to make change, we might as well make change, you know. It doesn't have to be right to left. But we're going to go right to left for a moment. Renzo Canetta from Bristol-Myers Squibb, Susan Dentzer from Health Affairs, Ezekiel Emanuel from the University of Pennsylvania. I guess you're getting a double duty here at this meeting. This is awesome. Bob Erwin from Marti Nelson Cancer Foundation, Barry Kramer from the NCI's Division of Cancer Prevention, Alan Lichter from ASCO, Therese Mulvey from the Southcoast Center for Cancer Care, and Paula Rieger, who is the CEO of the Oncology Nursing Society. Each of them has promised to spend just 5 minutes in giving you a quick reflection on paths forward, and then we're going to open the microphones for a few minutes of allowing you all to reflect some of the things that you think as we go forward. So if I could, Paula, call on you to start.
Thank you, Tom, and thank you for the opportunity to be part of the panel. I've missed the dreaded position of going last among the last, so I'd like to just share a few thoughts with you in reflecting on all that we've learned over the last day and a half and looking forward. And there were sort of 3 main points that came to mind. One of them that I think the system must begin to embrace and support to a greater degree, the importance of interdisciplinary team care. I think that oncology, as a specialist in a discipline, really stands out among other disciplines, but we always have room to grow and do better. And Brenda brought it up this morning about workforce. And so when you think about resources in our system, our workforce really is a valuable resource. So how we all work together and how we use those resources become critically important. And so one of the key points under interdisciplinary team care is that all professions be allowed to practice to the full extent of their licensure. And there's some excellent reports out there that you can avail yourself to. In 2011, the Institute of Medicine put out a report on the future of nursing, learning the change, leading the change, and advancing care. Advancing health. This is the most downloaded report from the Institute of Medicine, so I think that really speaks volumes. And there are other professionals out there as well, but I think that's something, if the system could take a look at that and maximize how we use the education, knowledge, and skills of all professionals involved in the care of patients with cancer, that might be something that would help us moving forward. Another is, as we look at how we educate healthcare professionals, that we think about moving towards education that gets us out of our traditional silos. Oftentimes we really don't have a full appreciation of what our colleagues can do. And so some of the colleges are beginning to look at this in new and creative ways, and I think it helps facilitate interdisciplinary care and the professions working together and appreciating and understanding what each brings to the table. Another thought is I think about the electronic health record. I think it's imperative as we look at capturing data in real time for practitioners that those systems are also reflective of the care of all members of the team and that actually it looks across the spectrum of care. My second point is talking about engagement of patients as true partners. And I think that Jesse spoke to this most eloquently this morning in looking at how we enable patients to make the best choices about their care based on their preferences. To me, there are several things that are really important as we look at making that happen, and there's been a lot of discussion on the alignment of the system to support activities that would make that happen in a better way. One of them clearly is for physicians in having those initial dialogues with patients about their preferences, honest appraisal of the outcomes, and what the costs are going to be. One of my personal soapbox areas is the critical importance of patient education. I don't think at this point in time our system really adequately addresses the ability to do that in the best way for patients and families. As we look at the push towards getting patients out of the hospital faster, decreased length of stay, and the rising use of oral therapies, that's going to be become even more critically important. We have to teach patients and families how they can self-manage, because we've asked them to take on a bigger burden basically in their care. So in order to try and prevent readmissions and unintended outcomes, they have to be knowledgeable about their treatments. They have to know what is normal and expected, what are the thresholds of things that they should immediately report to the healthcare system, and then what they should try to manage their side effects as well. Nurses are uniquely positioned to facilitate patient-centered care. We are the discipline that actually spends the most time with patients, either at the chairside or at the bedside. I will say that nursing is one of the most trusted profession in the Gallup poll for I don't know how many years running. And so how do we capitalize on that? Not to say that other professionals are not, but I think this is something nursing can be very proud of. So we're often the first to know if the patients and families are having any kinds of difficulties, be it financial, symptoms and side effects in managing their care, and how can that be used within the team to get the best outcomes that we hope for. Another one has been prevention, and I think many other healthcare professionals, as we look at trying to bend the curve more towards prevention, that empowerment through education on lifestyle changes is an important thing also to spend time on with patients and families. The American Nurses Association just put out a position on care coordination, and so they define that as helping to identify care options guided by preferences and to help patients and families maximize their independence and quality of life. Dr. Schrag yesterday talked about communication between patients, families, and providers. So this idea of coordination during transitions is critical. And how do we highlight that process and then recognize it within our payment system as well? My last point, when you think about transitions, is that importance of our primary care partners in assuring those smooth transitions. We all, as professionals, and I think especially as a professional association for nursing, we look at how do we help our colleagues become knowledgeable about what's important in cancer care, as increasingly we have survivors in this country that are transitioned back to primary care. So we have a project that we've looked at that was generously funded by Komen that actually looked at what kind of red flags should we help other professionals know about as they then begin working with patients after their cancer care. Thank you very much.
Thank you. Therese?
I'm Terry Mulvey. I'm a medical oncologist in Massachusetts, and I work at a disproportionate share hospital. And much of what I take away when I go back to take care of the 14 different types of lymphoma that will come in my office tomorrow is really centered around how is all of this going to affect those of us who spend 100% of our time caring for patients. And as I sit back and reflect on what we talked about, we really spent the better part of yesterday morning identifying the drivers of cost, including patients, payers, pharma and device makers, and providers. And I just wanted to take 1 second and say that all of us will need to address these 4 buckets of the drivers of cost. Patients' expectations will need to be reframed in large part because we, as the healthcare industry, have distorted the expectations that patients can come forward with. The payers will have a huge changes coming, as we've heard. The models will change, but as a practicing physician, I will make a very simple plea, and that is CMS needs to do something to stop the dance that they have with pharma. And until that is really addressed on a very fundamental and basic way, payment reform is really going to be nibbling around the edges. We'll need to invest in systems, and all of us, the payers and the providers, will need to make that investment going forward. The meaningful use payment is great, but it's not getting us to where we need to be, and I think we heard a fair amount of that by the community oncologists today. But focusing on the practicing physician, we clearly are on the glide path. And I would say that if you went out and asked 100 community oncologists, not one of them would understand that they are on the glide path. And so they're not doing the things right now that we have to do to be prepared because, like MMA, When the switch is turned on payment reform, and it'll have a fancy, nice little acronym as well, it's going to hit people like a ton of bricks. And so we have to have new models to enhance efficiency. As Paula just said, we have to work with the continuum of the healthcare team. We have to understand that patients don't belong to us, whether you say we're in the medical home, the medical trailer park, or whatever you want to make it. Those patients belong to a health system. And in my hospital, as an example, we chose an EHR that was oncology specific, and yet my primary care physicians who are employed by the same physician health organization chose a different health record system. I have read-only access, they have read-only access. That means I have to take the initiative to read it. This makes no sense. We have to reduce variability, and yet my fear is that we will use population-based metrics to superimpose on an individual physician-patient encounter. And when you do that, the R-squared coefficient will never be statistically significant. So we have to be very cautious about trying to make the perfect the enemy of the good. And all the while, we are going to have to try to hold on very tightly to community-based clinical trials. Because the models that we heard about took very select populations. Dr. Temmel is to be commended for her palliative care model, but we have to remember that's 150 people who found their way to Mass General Hospital. How is that going to apply to the 500 people who will come to my disproportionate share hospital with lung cancer this year, many of whom cancer is not the #1 thing on their problem list? It's homelessness, it's substance abuse, it's behavioral health issues. So where does palliative care fall in my hospital, and how will that model be transferable to me? I really worry that we're going to see consolidation. And that is a good and a bad thing. We saw it after MMA. US Oncology did not develop because they wanted to go out there and provide the best quality care to patients in Texas originally and then across the Southwest. They did it because the payment model changed. And we've got some very good things that have come out of US Oncology, but the same will happen when the switch is flipped. And what kind of unintended consequences will we see from that change in payment model? Will we have access issues? Will people belong to regional care programs? Will it look a little bit more like Canada, where the public drugs are given in public institutions? Will we shift more care to less costly providers? If that's a nurse practitioner or a clinical nurse specialist or someone, an oncology certified nurse in oncology, that's great. But what if it's a medical assistant? What if it's less skilled providers because the system can't afford more highly skilled providers? Will that patient feel that they've lost continuity of care during the trajectory of their illness? Where's the right place for patients to repatriate? Is it the week after they finish adjuvant therapy? Is it a year after they finish adjuvant therapy? Where does that happen? And these are decisions we'll need to make fairly soon. And my last point is that physicians are smart. All of us were the smartest kid in our grade school. We probably all finished in the top 5 of our high school class. And when you flip the switch, enough smart people will figure out how to build a better mousetrap and game the system. And I say that because of MMA. After MMA, we figured out that the way to maintain our salaries, I live in the People's Republic of Massachusetts, Tom, we don't make $407,000. We have healthcare reform there. But I just have to say that, we figured out that we could maintain our salaries by seeing more patients. And I would argue that if you asked any health system, Kaiser, Geisinger, any of them, what is the thing they tell their physicians the most? It's how many patients they need to have in their panel and how many patients they need to see per day, because that's how we keep the lights on. When the switch is flipped to a different payment model, smart people will figure out how to maintain the status quo, and the unintended consequences for patients could be significant. I don't know what they are, but they are definitely going to happen.
Thank you. Alan?
Thanks, Tom, and congratulations to Patty and the organizing committee. This was a terrific meeting with so many interesting and exciting presentations. But I'm concerned, and because we hear all these things, and as Tom mentioned at the beginning, there's no plan or pathway to adopt and scale some of these things. We recognize we have a fragmented healthcare system where incentives are not aligned due to that fragmentation. And we've decided to take a fragmented approach to fixing it. And I don't think that's going to work. We have to figure out how we do things together and collectively and understand the best stuff and push it out through the system. And I just want to talk about a project that ASCO is involved in that helps address that. And it comes from, spins off the recent ION report on the importance of the learning healthcare system, the ability that we have now as we reach a tipping point with electronic records to actually begin to collect data, to normalize it, to aggregate it, to analyze it, and to feed back what works or not. We know cancer is complicated. We know that lung cancer, if you begin to start talking about the various stages and age groups and levels of comorbidity and the molecular markers and on, is quickly devolving into hundreds and hundreds of individual cells. Our ability to sort this out cannot be done by individual institutions. Where it's going to have to be sorted out by us putting together our data and combining it and feeding back into the system what works best and what doesn't. I was intrigued today to hear in Kaiser that their experience in certain subgroups of patients who get TC chemotherapy for breast cancer does not conform to the clinical trial of less than 20% febrile neutropenia. It's more. How many of those things are going on as we roll out our standard regimens into populations of patients who were not eligible for the trial? It's going on, and you all know it, hundreds and thousands of times. And the ability for us to collate that data, to analyze it and aggregate it and feed it back becomes critical. It is a cultural change in our lives to say we should do this all together. So many of the solutions are interesting, and academic careers are built on studying these things. Individual groups, their business model is to do it and to do it better so that more customers come their way, et cetera, et cetera. So we are acculturated to do things individually. We must at least begin to change that culture and collect data. I just say just a couple of quick more things. No amount of clinical trial work will dissect this problem and solve it. There's just not enough clinical trials that could be done in the history of man to sort this out. Plus, the system is dynamic and changing. We must do it in real time, and we must do it through data collection. It was a talk today, one of the blunt instruments that payers use to help solve the cost problem is something called prior authorization. Try to order a cross-sectional imaging study today or prescribe an expensive drug, and you will enter this twilight zone of an arms race where somewhere sitting off in an insurance company is a floor full of people who have this bobblehead doll that says, no, you can't have this test. And in our offices are staff members whose job it is to fight back and forth. There is no value added in this contest, but there's huge amounts of money wasted inside the system. What if we had a system that could say, here is the appropriate amount of PET CTs that should be done in this population of patients? And Dr. Schnipper's practice is absolutely at that in that green zone in using that particular study or test or drug in that particular population of patients. Why would you spend thousands and thousands of dollars doing prior authorization to the practice when you know they're doing it right? When we combine data, the ability for us to streamline the system, to make it work, become better. So ASCO's board has said, let's do this. This is a technological lift, but the main thing is it's a cultural lift. We hope as we roll this out, people will join us. Thanks, Tom.
Thanks, Alan. Barry?
Again, thank you so much for the invitation. I think originally it was supposed to be Dr. Varmus himself. If he had attended rather than I, you would have heard a much more eloquent presentation and no slides. But I have to substitute eloquence for slides. I'm going to try to cover two issues that I don't believe were covered at all, at least not in any detail. One of them was very, very briefly covered probably by Otis Brawley yesterday, but there were no formal presentations on it. And the other was not covered at all. I'm going to go back to a theme that Emanuel covered, and that is we are the problem. I really do think that physicians are in large measure the problem, and so it's not going to resolve the issue if we simply say that everything has been imposed, the system is imposed on us. We are part of the system. And we are the product of our training. And I'm going to give you a quote from Ken Ludmerer, who published Time to Heal at the end of the last century. And his book, Time to Heal, was hailed as the Flexner report of the 20th century. And I think in many regards that's true. And toward the end of the book, he pointed out that the worst lesion, the major lesion in medical training, is a failure to train our learners for clinical uncertainty. And that has led to the systematic overuse of practice of tests and procedures and treatments. So this is the consequence of that. As soon as new diagnostic tests became available, they went into immediate use. Because I think we were training medical students the wrong ways, and after you get out of medical schools, your belief system is carried for the rest of your career, and this is what has happened. Some of the increased use has been appropriate and helpful, but we don't know what proportion is actually helpful. We train our students the wrong way. And that is, here is the consequence, which is translated, it becomes overdiagnosis. That is, we're diagnosing many lesions that are not life-threatening. This occurs along with almost any screening test that comes along. And that means the beneficial ones, and that means the worthless ones. Almost all screening tests are associated with an element of overdiagnosis, as we briefly talked yesterday. But we're training medical students, and therefore physicians, to focus on the upper lines, the yellow curves in each of those diagrams. That is, they are trained to think that if you see something that you wouldn't have been aware of, then that's a good thing. It translates into a good thing, but it's a double-edged sword, and I don't think that we are training medical students and physicians well enough. They don't focus on the growing disparity between making diagnoses and actually the true health outcomes, which are the blue curves there. That is the much more modest change in actual risk of dying of all of these diseases. We are diagnosing huge numbers of cancers without necessarily having a concomitant effect on the risk of actually dying. And even worse, this is a cartoon from the far side. We have to learn the lesson from this slide. We cannot shoot first and then start asking questions. And this is a problem, as you heard yesterday, with the PLCO, a randomized trial, where we launched, created the world's largest epidemic of prostate cancer simply by screening with a very simple screening test, PSA. But we didn't have evidence in hand to know whether we were actually helping people. We diagnosed approximately 1.3 million men with prostate cancer that wouldn't have been diagnosed had it not been for screening. And we viewed that as a benefit. And we don't know whether it actually translates into a reduction in risk of dying of prostate cancer. And we failed to train physicians, medical students, that might be the case and to be aware of that. It also harmed our ability to ask questions because obviously the biggest problem with these randomized trials were contamination. That is, we had already convinced the public that screening in any way, shape, or form is all good, no downside. And so there was huge crossover in the control arm to be screened, and that was the the most prominent weakness of the trial that asked the question for prostate cancer. The trials that were conducted in Europe had their own problems, so that there was no perfect trial, as you can imagine. So that's training. And I think we need to start in medical school because that's where belief systems are formulated. And the last issue I'm going to cover is how to express the evidence to both physicians and to patients. And we don't do a good job of that. This gets into the lack of training in probabilistic thinking as well. Denny Aberle did a superb job yesterday covering the complexities of the National Lung Screening Trial. But how do we summarize those complexities and transmit them to physicians and to their patients? Well, at the National Cancer Institute, working with the investigators in the National Lung Screening Trial, we developed a one-pager that goes into those issues that we hope will actually inform physicians and patients about the absolute magnitude of benefits and absolute magnitude of harms when they enter into this discussion. So at the top we say who was exactly eligible for such a trial, what's the purpose of the guide, and then we have the equivalent of a drug box. That is of 1,000 people that get screened with either low-dose helical CT or chest X-ray. What is the difference in outcomes, in health outcomes, on the beneficial side at the upper half of that slide versus the harms on the lower half of the slide, so that both physician and patient know in absolute terms, not relative terms, the issues. And finally, we wanted to emphasize that the most important thing you can do is to stop smoking. The benefit that is afforded by screening versus not is paled by the benefit of stopping smoking or not starting smoking if you don't smoke. And so I think it's, and we give a quit line for people who want to quit to smoke. That's the action item on this description. So with that, I'll stop.
Thank you, Barry.
Thanks, Tom. Human life is sexually transmitted and 100% fatal. But how many oncologists are comfortable talking about either sex or death? You know, words are extremely powerful, and the use of words can lead to very positive outcomes. It also can lead to unfounded beliefs, unrealistic expectations, and a willingness to overpay for things that don't work. A linear extrapolation from the annual reports of the NCI in the 1980s or from the Wall Street Journal or the New York Times of that period leads to the conclusion that cancer was cured about a decade ago. So we have a real problem with how we communicate what we know and what we believe, and of course knowledge and belief has been addressed in this meeting, which I think is very appropriate. And anthropologists might argue that if we really want to make a change in our condition, we have to change the narrative that we use to describe our condition and our objectives. And that will certainly require a great deal of transparency to make it quite clear what the conflicts of interest are and the vested interests and all of the other factors that lead us to deviate from pure objectivity to other things that lead to propaganda and false beliefs. I'm certainly not opposed to the concept of curing cancer, but having worked for many years now as a patient advocate with individual people, helping them make treatment decisions and plan treatment, I have to admit that I've become a little bit cynical about what people's expectations are, both among patients and particularly among the people who populate the healthcare system. What I do think, what I hope, and perhaps even believe, is that were we able to address the poorly accumulated, poorly organized, and poorly disseminated information and data that we already have, we could do a lot better job of determining within this vast cloud of information for any individual patient what is the probability of benefit from any given compound. And unfortunately, it's belief about the compounds or the interventions and the devices that go along with them that lead to this willingness to overpay for things that just flat don't work. So we need to realize that clinical trials and the kind of evidence that we tend to consider to be the gold standard is not particularly good at guiding clinical practice. Clinical trials generally are designed for publication or for product registration. I would argue that when a drug is first approved on the basis of a randomized controlled clinical trial, virtually every patient that's treated on that drug post-approval is treated off-label because the entry and exclusion criteria are so narrow that they don't really provide guidance to the physician about that population. So what's the solution? Well, there have been a lot of great ideas proposed yesterday and today. One thing that I would like to see done is a greater emphasis on conducting studies probably initiated by the government. The kinds of studies that any one company is not able or is not willing to do that will provide better clinical guidance to physicians and to patients, which will mean validating more biomarkers, using diagnostics aggressively but appropriately in combination with therapies, and better characterizing the cost and quality differences and comparisons of this incredible number of extremely expensive drugs we have that really fail. They fail more than they succeed. And back to the use of words and the narrative, we talk in terms of treatment benefit and cure. We don't talk in terms of failure. But failure is a huge part of oncology, and it's a natural part of such a complex biological and medical problem. We need to embrace that reality and communicate it better, and then try to sort out how to make the decisions for each individual patient, one at a time, that ultimately will lead to the entire population being better treated. Thanks.
So I guess I'm doing double duty. I did make a set of slides based upon some thinking of where we go, since, as most of you know, I don't like just to attend meetings for meeting's sake, but I think we need to actually do something here. I did note, and I could be wrong here, but I had a sort of urgency meter, and I noted that the two guys with the most service inside the Beltway and the most bruises for that service, Mark McClellan and myself, I think sounded the most urgent here, and maybe you have the same perception. Something is going to happen soon, and either we can anticipate it, be ready there, or we can continue to talk and deliberate and talk about glide paths. I just want to say it's rare that the Beltway is wanting to push faster than everyone else in American society. But this is a case. And mostly I think it's because Mark and I have this sort of economic bent. We've looked at the deficit. We understand what the sequestration means and the fact that there will be a budget deal sometime, which is going to take huge whacks. You know, they're talking in this town $400 billion out of Medicare, all right? If they're talking those kind of numbers, and that's from among Democrats, guys, something big is going to happen. We have to be much more urgent than we'll study it, we'll issue a report from this meeting. So it's in that light that I offer the following 5 ways forward. All right, first, and I'm going to elaborate each one, I think we need to add to choosing wisely. Second, require guidelines to rank chemotherapy by price. Third, support insurers paying for adherence to guidelines, standards of care, pathways, whatever you want to call them. Fourth, explicit call for payment system change, and I'll elaborate that. And last, require, don't talk about patient education, patient engagement, do something about it, and let's be specific about it. And importantly, I think these are mutually supportive, that we actually get a synergistic effect by doing all of these. So we have 5 interventions on choosing wisely. ASCO, Lowell, the whole committee that worked on that need to be commended. We need to add 5, 10, 15 more. We know that they're out there, right? I mentioned at least 3 of them that aren't on Lowell's list. Many other people could add more. We need to get them out, and we need to get them out promptly. I've been urging this, I think we, 2 nights ago, were thinking, I think it was 2003 when I went to the CCE, Bobby Green's group, and I said, you guys got these pathways, and at that time they had like 5 or 6 chemotherapy regimens for Hodgkin's disease or breast cancer. I said, Do you rank them by cost? And do you say, guys, we got to do the cheapest one top? No, they didn't do it, and I don't think they still do it. We've seen the gastric cancer data that was presented, 55-fold difference in the chemotherapy costs, right? I think on our guidelines, we just have to do it, rank them by cost, and say, we think the top one is recommended and should be what you do, unless you have a really good reason to go down that list. Now, there are going to be good reasons 5 or 10% of the time. Support insurers. We don't like to say no, right? We don't want to be the bad guy, right? We want someone else to say no. We want insurers to say no, or Medicare to say no. Therese just said that. If we want that for our benefit, we have to support insurers in that. Because their perception is, we keep getting beat up on this. And by the way, it's oncologists who do a lot of the beating up, supporting the patient advocacy groups, supported by the pharmaceutical industry. If we want them to help us, and the help, I think, is not so much by no, but by saying, we're going to pay for adherence to the guidelines, and we're going to ask you to do that. So going way off base is not, and you saw Lee Newcomer's data on Avastin. That was pretty impressive. Where they cover Avastin for metastatic breast cancer, which already is ludicrous in my opinion. Just getting people to adhere to those guidelines was more than a 50% cut. It went from 55 cents PMPM to 20 cents PMPM. Seems to me we ought to get into an agreement with insurers that this is a good thing to do. We need to get in there and call for explicit payment change. Sometime in early 2009, I made a telephone call to a man at this table who represents ASCO, figure out who it is. And I said, I need you to develop a bundle. I want the professional society to develop a bundle around adjuvant therapies. And to his credit, he did it. But he did one bundle as opposed to multiple bundles, and it has taken forever. I don't think we have that luxury, and I'm really being serious. We cannot do one bundle, get everyone used to it. Things are going to go much more rapidly, and I believe they could go pretty cataclysmically if we don't get on top of it. We must get out there and say very explicitly to insurers, but more importantly to the federal government, since I would bet in most community practices 50+% of your billings is Medicare, just by the nature of the illness. We want bundle payments now. We want accountable care groups with global payment, whatever structures you want, cancer medical homes. We want that change now. We want a schedule for it, and we're going to be on board. They need to hear you. And I don't think we have an alternative here. I really don't. Every time people say, we don't think this has a lot of value, but we're giving it, that's all about getting us off this fee-for-service payment system. We really need to do it. Patient engagement. This idea that we need to talk about cost control or costs of treatment that's not patient engagement. That's information to patients when they're least able to handle that information. That is, in my opinion, ridiculous. Right? You are facing a life and death situation. It's probably the biggest crisis you've had in your life in a while, if not in your entire life, and you want to focus a patient on, let's get them engaged. Now, I got up for a reason. In my hotel room, and I don't know how many of you actually noticed this because it wasn't actually prominent, it fell under some newspapers, but this morning I found it. Got a little thing that said reduce. I'm a cheapskate, so I'm always interested in the reduce. And it says, pass on housekeeping. Don't have housekeeping, and we'll give you a $5 voucher. First time I've ever seen it in a hotel, right? They're paying me, to live like I do at home, right? I mean, I don't know how many of you have daily housekeeping in your house, not in my house. The Emanuels are cheap, right? So I think we need to think seriously about patient engagement, and this, again, is not information to patients. If my hotel can pay me to pass on housekeeping, and they're paying me, obviously, a fraction, costs them, what, $25 to clean my room, $20 to clean my room, something like that, and they're giving me $5. By the way, Medicare also pays patients to do something different. In the ACE demonstration, patients get about $275 or $375 to go to a place that's handling bundles. Here's a simple question. Why can't we pay patients directly? We got all those gastric cancer things. You can get $1,000 if you choose the one that's less, and it might be even worse for you, right? Might require transportation, you have to wear a pump on this, etc. For chemotherapy with the same results. The insurer's going to save money on that. If they're shared savings, the doctor will save money. Society will save money. Where's the patient in this? They have to wait for their premiums to come down. Their life might be short. They've got to pay a copay. I think that, this is coming from the ethicist, I'm not sure I see why that's unethical. I know it might give people the heebie-jeebies. You're paying people to do something cheaper. Damn right. As long as it's equivalent and you've got the same results. We're not asking them to sacrifice any survival benefit. Anyway, those are my 5, and I think we have a sense of urgency, as you can tell in my voice. I don't think we have a lot of time, and I think we need to be proactive, and I think if the report of this comes out and basically updates Scott's report, that's not going to be very productive use of our 2 days. And I wasted lots of calls to organize this meeting with Patty, which I normally don't do, but who can say no to Patty? And 2 days here because I do think we are at a moment where the cancer community is ready to change, and we need to tell them how to change and to lead that change and not miss this wonderful opportunity. Otherwise, I think 1, 2, 3 years down the line, we are going to regret not having been much more proactive and much more out there. Now is the time to take a risk.
Susan?
So many of you will know the famous saying of the late, great Congressman Mo Udall, who, when he chaired various committees, would always say to people, everything that has already been said, deserves to be said about this subject has already been said, but not everybody has said it yet. So we're going to let everybody say, continue in this vein. And I'm tempted to point to that again, because I really could just say what they said and pass things over to Renzo, and that would be enough. I think all I will add to this amazing discussion, and Tom, particularly to your summary, is what the last couple days have surely reminded everybody is that cancer merely exposes all of the strengths and all of the weaknesses in the healthcare system on steroids. Because it is such a prevalent set of conditions and so costly, it simply magnifies what we know to be true about the totality of the healthcare system. For example, we know that about 1/3 of what we spend in this country is sheer and utter waste. Probably it's possibly even more than that in the case of cancer. It might be as much as half of what we are spending is wasteful. And this came home to us in spades. Some of you may know we at Health Affairs published this issue back in April, Issues in Cancer Care, Value, Costs, and Quality. And if I just read you some of the titles, you can see this in spades. Appropriate and inappropriate imaging rates for prostate cancer go hand in hand by region. End-of-life care for Medicare beneficiaries with cancer is highly intensive overall and varies widely. Growth of high-cost intensity modulated radiotherapy for prostate cancer raises concerns about overuse. Direct-to-consumer internet promotion of robotic prostatectomy exhibits varying quality of information. It's the same set of issues that we see throughout the healthcare system. It's variation, it's lack of transparency, it's pricing. In the case of drugs, we know that overall about half of our health cost differential relative to other countries is prices. Well, welcome to the world of pharmaceutical pricing in the cancer area. So we not only have met the problem, and it is us, we have met the problem, it is our system. It is our system of dealing with everything in healthcare in America. But again, just magnified by the fact of the matter that it's with cancer. So what would I do about all of this besides what they all said? I would come back to two phrases that have already been said again and again and again. It sounds like the last couple of days: transparency and patient-centeredness. Transparency, why? Because as we see, the more that we expose what we are actually doing and what the actual results are, the more we see this unnecessary spending and crazy variation, and understand its lack of utility for patients. So just to give you an example of some models that are emerging in other areas of healthcare that could be useful to apply back to cancer. We have published some work done by something called the High Value Healthcare Collaborative, which is a group of the large healthcare and hospital systems in the country that fancy themselves among the nation's best. This would be the Mayo Clinics and Intermountain and Dartmouth-Hitchcock Medical Center, among others. Cleveland Clinic. They started off with 5 of them. They've now grown to in excess of 15 institutions participating. They said to themselves, well, we think we're the best. If we are the best, let's see. And let's start by pooling our data among ourselves to see what we do for patients. They started with knee replacement surgery, something very much out of the cancer sphere. And pooling the data just among the 5 institutions, they see things like 30% plus difference in length of stay, 50 or 60% plus differences in complication rates. Interesting insights about how much time patients spend in surgery and the direct relationship to complication rates. So already just among these institutions, by pooling their data and looking at their results, they've already identified a number of innovations that they can share across this high-value healthcare collaborative and make an immediate difference for patients. And nobody told them to do this. No government agency required them to do this. They just said to themselves, if we think we're the best, let's find out if we really are. And I think the opportunity for those models to be tried across some of the major cancer treatment centers in this country would be extraordinary. Patient-centeredness. One of the most powerful pieces that we ran in this issue, some of you may have read, it was written by Amy Berman, who's an officer at the Hartford Foundation. And this was picked up by the Washington Post and many other media entities afterwards. Amy is a 50 or so year old woman who was diagnosed with inflammatory breast cancer. And because she's also a nurse and has a long experience in the healthcare field, she did not take lightly any of the advice she got from any clinician. She went to see the most prominent clinicians in the field on inflammatory breast cancer, read the evidence herself, and concluded that there was nothing out there really that was going to help her. Despite the fact that some of the most prominent clinicians in the field counseled her on mastectomy, regimens of chemotherapy, et cetera, et cetera. So Amy elected, rather than angle for quantity of life, to angle for quality of life. And so she has elected an extremely conservative course of treatment, which is more or less no treatment. And she wrote about this very movingly in our journal. Now, that is, Amy's choice is not the choice everybody will want to make. But it does tell you what happens when you have an extremely well-informed patient who looks at the evidence and who is strong enough to overcome all of the advice she gets on the clinical side, almost all the advice she got on the clinical side. And I saw her last week, and she's doing fine. She wants to die, as she says, like Niagara Falls. She wants to live to this level and then suddenly go over the cliff, rather than spend the last couple of her years in sequences of chemotherapy, et cetera, et cetera. So what do we know from other evidence about the phrase that Zeke mentioned, shared decision making? We know from almost every study that's ever been done on shared decision-making, which, by the way, is in the Affordable Care Act, and is one of the things in the Affordable Care Act which has neither been publicized or taken up. But it is in the Affordable Care Act. What we know from shared decision-making is that when you expose patients to careful, accurate evidence that clearly lays out the risks and benefits of treatments, 9 times out of 10, patients will pursue a less risky path than their clinicians would have recommended, and they turn things down. And just recently, we published how at Group Health, again, back to knee replacement surgery and hip replacement surgery, when patients were shown what the actual data suggests are the outcomes of these surgeries, large percentages of them elected to forgo the surgery. And I suspect much would be true also in the case of cancers, if people were truly given the evidence, particularly for what we have available now on metastatic cancer. Again, it's not going to be the right decision for everybody, but it's going to be the right decision for a lot of people and then an informed one. So just to close, if we could create systems that were sharing all their data, that were evolving a very patient-centered model that truly put the patients at the center of decision-making, and were extremely transparent about everything that they did for patients and every result that they had achieved, that alone would drive us to a very, very, very different healthcare system, and it would be a model for the rest of our system. Thank you.
Okay, we've been provoked by the moderator to be short and to be propositive. So I will limit myself to only 3 points, and the 3 points are cost, risk, and value. And I'll do that from the perspective of somebody who is involved in research and development. So if you believe that the healthcare cost has increased, make no mistake, the cost of development is also increased. The latest statistics tells us that to bring successfully a drug from the first in human all the way to the general use, on average, for every disease area, cost $1.2 billion. Keep that figure in mind. It ain't cheap. Why is the cost so high? Well, there are a number of complex reasons. The scope of the development programs that we run, the multiplicity of countries that we work into. Now we're in a global type of enterprise. The complexity of the data collection, the type of data that we are mandated to collect, and sort of systems that are mandated by different health authorities, even for the same program, even for the same drug. So what do we do about it? Well, what we started doing about it is nothing very different from what ASCO proposed to do to the ASCO member. We started looking at things that we're doing and asking, what is the value of what we are doing? And I'll give you just one example of that because it's a recent example. As you may know, in the past, the FDA has asked us to provide an independent blinded radiological review of tumor measurements and disease progression for our pivotal trials. And we complied because we always comply. But also, we've been trained to be investigators, so we looked at our data. And we figured out that there was never a discrepancy between the investigator, institution radiologist defined outcome and the independent radiological review outcome. There were differences numerically, but if a trial was positive, it was positive by both accounts. If a trial was negative, it was negative by both accounts. So the one thing that we did is that we went to another company. We started with Genentech, and we asked them, have you had the same experience? And they said, well, now that you asked, actually, yes. So we involved 2 or 3 other companies, and then obviously because we are the bad guys from the industry, we ended up donating all of our data to NCI, to the biometrics branch of the NCI, and we told them, you know, we donate our data, tell us whether we are right or wrong. And they did the analysis, and guess what? They agreed with us. Then we went to the FDA, and we said, well, you know, probably you have more data than we can possibly gather together because we are the center of information. Is it true or is not true? And they did their analysis independently, and guess what? They came up to the same solution, outcome. There was an ODAC recently, and at that ODAC, basically the FDA ruled that it is okay now in primary endpoint of pivotal trials with a time of event endpoint to rely upon the institutional assessment, with the exception of certain rare diseases. And in fact, they could find one exception, only one single trial that was done in carcinoid. And this is probably because the radiologists at the institutions did not see that many of these cases, and the central radiologist was a very experienced one. And then in that particular trial, there was a discrepancy, but that n equals 1 in a database with a large number of randomized trials. Now, I'm saying this not because this is going to solve the issue of cost of development, but I'm saying this because this is a method that can be applied. And the method implies sharing the data and asking questions of our databases. Point number 2, risk. Today somebody mentioned the oil industry. I don't know much about the oil industry, but I know that in the pharmaceutical industry, the success rate when you bring a drug to the clinic is 25%, and I can assure you that in oncology is at the lower end of the spectrum. So we're not doing very well in terms of succeeding. Now, I know a little bit about the car industry, so if you're in Detroit and you design a car, you know that you're going to end up with a car. It may be a bad car, it has happened often in Detroit, but it's still a car. When we start in R&D, we might end up in the middle of the process or even at the end of the process because unfortunately many of our drugs have failed in phase 3. We end up with nothing, not a bad drug, nothing. And that's something that poses us a big question. Number one, are we adequate to the role that we have in society? Because our responsibility is to bring effective treatment to society. And number two, how can we afford this type of risk? And is this risk valuable for society? So what has been done in order to reduce the risk? Well, we needed to constantly challenge the process by which we develop our treatments. Another thing that is being done more often in these days is a sharing of risk with companies collaborating with each other. One thing that we proposed through the National Cancer Policy Forum was something that now has been evolving into a proposed FDA guideline for co-development of experimental agents if there is a possibility to produce a synthetic lethality. This has to do with blocking parallel pathways, for instance. And we're doing that, and there are other companies that have started to do that. We started a pre-competitive collaborative agreement with 9 other companies to work on preclinical research. So there are things that can be done and should be done in order to improve the results and reduce the risk. At the end of the day, however, I still maintain, because that's my job, that's the way I've been educated, and that's what I do for a living, that doing research involves risk-taking that is of value to the society. And that brings back the third point, which is value. And Lee Newcomer today spoke about agreement, societal agreement on the value of what we do. And Robert Greene actually spoke about misaligned incentives and aligned incentives. I believe the two things are the same thing. We need an agreement of the value of what we are doing. And I can tell you that, yes, there are new drugs that bring about marginal outcomes improvement, but there are drugs that actually bring important improvements. I am old enough to have lived in an era where we didn't have much for patients with metastatic malignant melanoma. Now we have patients that maybe paying $30,000 a month, but only for 3 months, but then be alive for up to 7 years, if you believe Steve Rosenberg, up to 5 years, if you believe to our updated data as presented at ESMO last week, or up to 2 years if you read the package insert of ipilimumab. So yes, that price needs to be spread over 60 months or even more months. But the point is that what happens to these patients? I mean, these are patients that are alive. I'm very hesitant to use the word cure. Other people say, oh, I cure my melanoma patients. We don't say that. But I've seen time and again coming up in HIV and chronic myeloid leukemia, the issue of functional or operational cure. These are patients that live with their disease with a minimal amount of symptoms and a minimal amount of toxicity for their treatment. These are patients that return to their productivity, that return to their normal life, and the value of this has to be factored in. Keep it in mind at the other end, and I'm very grateful to Jessie for her presentation earlier this morning, that there is at the other end of the spectrum a value for patients that might not be doing that well, and for whom we need to provide the appropriate care. And the appropriate care there may or may not necessarily encompass a new drug, may encompass only an appropriate palliative supportive care. Having said that, I believe that only the concept that we are all in the same type of boat, and we might have different employers, but at the end of the day, progress is going to come only from collaboration and not from creating, little parishes where we fight against each other on petty issues. That, to me, is one of the ways by which we can make progress in this issue.
Thanks, Renzo. So we have time for about 3, maybe 4 comments at the most. If anybody have any comments that you would like to add to the group discussion? Everybody's ready for lunch? Oh, Patty?
Ezekiel, what can we do? I mean, you basically said, it's going to be 6 months till we have a report. It's going to be an update. We'll have a committee study. As people who live in America, as experts and people involved in the healthcare system, what is the political or academic or community action that we should respond with to the urgent call that we all heard?
I think we do have to get a list of to-dos, which include to-dos that we're going to do and to-dos that we're going to ask others to do, but we're going to support them even when they're going to have to take heat for doing it. And I gave you my to-do list, but I think we need to get that. I think the follow-on of this meeting should not be 6 months from now. It has to be promptly. It can't just be, well, we should talk about low-value treatments. And we've got a to-do list. Mine's not comprehensive. It's just what I thought of last night.
So what you're saying is through our organizations that we represent, or constituencies that we work with.
We're often criticized in various government for, getting everyone together. And I often ask, well, how easy is it to get some major change at your institution? We can't take that usual timeline. And I'm being very, very serious. I think it's something is going to be done, and either, they're going to whack payments again, because as you heard from Mark, that's the easy and most reliable you can get scoring on it, or we're going to do something more creative. And I think we need to offer, Washington doesn't think of these things, we need to offer the creative solution. There are lots of outlets. We've got ASCO and JCO. We've got a big, we could write an op-ed which would get a whole lot of attention, I assure you, if we did anything bold. I think if the Institute of Medicine came out with a report that had some bold suggestions, that gets a whole lot of attention in this town. I think the same old that we get out of many Institute of Medicine reports, here's a summary, here are possibilities, here's one of them, it'll get the same dust that, most reports get. So I just don't, I think we do have an opportunity here for a political statement, and I think it's an important political statement because it's not political in the negative sense, it's political in We need change to help us do the right thing. I think that's what we've been hearing. We can't do this alone. We need a structure. We need payers to help. We need government to help. We need patients to help. But we're at this moment. And I assure you, you know, if you talk to people inside the Beltway, we are in a very big budget situation. And that's going to drive everything. And Medicare is, as I said, they're talking about $400 billion cuts. That's $40 billion a year for those of you where the math is hard, right? Think about that. Do you think the SGR is bad?
You know, I just have to say that you know, when you talk about we just have to do something. We don't have time to do pilots. I have to disagree. You know, we all agree that one of the fundamental things that we have to transition to is we have to take the drug payments, so-called buy and bill chemotherapy, away. It's just not going to last. But that's 75 to 80% of the revenue that comes through every oncology practice. We simply can't just say, well, we're going to do it. We have never tried it. And we don't understand the ramifications, and we don't understand the second-order effects and the third-order effects. We're just going to bet the whole damn field. This is not like saying to an ophthalmologist, you know, that your diabetic patients, you're an endocrinologist, your diabetic patients only need a retinal exam every 3 years instead of every year. This is the farm, and it's easy when, you know, to stand back and say, well, just do it. We need to pilot. Zeke, we did the demo project that you asked us to do. We took it to CMMI in October of 2010, where it still sits. We've been back to them, and we cannot get anybody. Had we done that pilot in 2010, I could sit here today and tell you how it worked.
Alan, let me say two things. I agree with you that we're not going to flip the switch. But that's different than saying we want to schedule over the next 5, 6 years, pick your timeline, where we're going to do the following things in a partnership. We're getting off the fee-for-service system, at least for these following things, where we have very good guidelines, we've got very good agreement, right? I mean, we've got a lot of rain areas. I mean, Lee's got, is it 22 bundles already? You may not agree with his bundles. You can modify them. But we've got plenty of guidelines and pathways that we could use for a bundle or a global payment. And we could establish a schedule we're going to agree to.
CMS
No.
to do it.
My
We're ready to do it. We need a partner that's willing to do it with us.
Lowell. Yeah. Alan, it's a little different going out there, and I know the frustrations of dealing with that organization. And I think they're in a different place in 2012, I could be wrong, than they were in 2010. And it's also possible to say in a declarative sentence, we're ready for this. Here's our timeline. We want to do this. We want the government to come and agree that we're going to get. That would send huge shockwaves in the government, I assure you. The White House would call them and say, get on it. You have a professional society which is willing to get off this train, and you're not moving. And I think you could also get insurers in it a lot faster. That's my bet. And you're right. We can't just flip the switch. I'm completely agreed with you. I said, I believe, we spend $2.8 trillion, fifth largest economy in the world, and you're not going to change it overnight. On the other hand, you need to think about what the alternatives are, because policymakers have few alternative levers to push, and they're going to push them whether you like it or not, whether it's good for your patients or not, whether they've thought about the third order consequences for your patients or not, because they have their own imperatives, which is called, you know, getting the budget under control. So we may not be urgent, we may not be there, but the alternative to me looks really ugly.
So I'm going to take prerogative since we have just a couple minutes. I'm going to turn it over to you, Patty, or Tina. Okay, so I'm going to go back where I started with this notion of dichotomies. So what we just saw was an exchange that reflects to me one of the big dichotomies we have is on the one side we have urgency. There's no question we have urgency. We have the fiscal cliff facing us. Lord knows what will come out of sequestration, but I'm doubtful it will be better than whatever sequestration is. So we have urgency. On the other hand, we have all these changes that we have to make that require cultural shifts which do not happen overnight. The question is how we respond both to the urgent need that we have immediately, and you made some suggestions about that, and then to the need to make these larger cultural shifts where we have the proof that we're making the right shift, which is more where Alan is. I don't actually see them. I know there was a bit of an argument going there, but we have to do both things at the end of the day. The question is, how do we get the urgent thing moving quickly, because urgency is urgency? How do we then decide what is the rest of the agenda and how long it takes and when to get there? And in that vein, we do not have right now the mechanism that allows us to have that conversation. And maybe we need to create that conversation. I'm reminded years ago when Governor Kitzhaber came to a sea change meeting and kind of got people fired up because he said, look, let's compare this to public education. In public education, we had a societal discussion. We decided that K through 12 was right, and when we reduce funds, we lose money. We don't get rid of K or 1. We actually spread class sizes out differently, et cetera. He says, we've never had that conversation in healthcare. And he said, if we don't have that conversation, we're never going to get there. We still haven't had that conversation, although we've had a lot of really good ideas come out of this. So Tina, okay, one of you. By the way, thank everybody on the panel.
Yeah, I don't have any slides, and I think when we started this meeting, we do have a sense of urgency, but Zeke put us, getting us even more nervous now. I wish I can design an economic model and everything resolved in a model, but that's not reality. So I think what we learned from this meeting is there's a lot of, when we're talking about affordability, there's a lot of stakeholders at stake. We're talking about patients, we're talking about payers, we're talking about oncology practices. Then going to the model, we're thinking about learning disabilities and in organizational value. We are trying to find the solutions. Think about the enemy is not out there. We're the one creating the problem. How do we come together to solve the problem? I think that's really the take-home message from today's meeting. I think we have a very, very productive 2-day meeting. Thank everyone for your contribution and for your thank the panel for a wonderful discussion. And all the slides will be ready online, I think, in 2 weeks, and then there will be a proceeding. In the meantime, if you have any suggestions, feel free to send me an email or send Patty an email. Thank you very much for attending.